Thank you very much. Our last speaker of the session is Dr. Hamid Shareef. He's assistant professor at Rawalpindi Institute of Cardiology, and he'll talk about role of IVUS in precision PCI.
So, Bismillahirrahmanirrahim. I'm Dr. Hamid Shareef. I'm working as a consultant cardiologist at Rawalpindi Institute of Cardiology. So, today's presentation for me is the role of IVUS and OCT in improving clinical outcomes as far as stenting is concerned. So, I will discuss the following points. The PCI outcomes as measured by TLRs and TVRs, what are the underlying causes, and what's the role of imaging. I will discuss the evidence behind IVUS and IVUS criteria for stent optimization, which is very important for you to know as far as the fellow course is concerned, and evidence behind OCT and also OCT criteria for stent optimization. So first of all, we all know when it comes to CABG versus PCI, it's always the TLRs and TVRs which brings the PCI down, because repeat revascularization is always almost the case when it comes to, if you look at this study, the Syntex trial in multivessel disease, when compared to other outcomes, you see death, all death, MI, CVA, there's not much difference. But when it came to revascularization, 23 versus 11.9, and that is the reason the graph deviated. CABG was considered superior in Syntex trial. Similarly, in the Excel trial, if you see, all of these graphs are overlapping when it comes to stroke, myocardial infarction, death. But when it comes to TLR, that is ischemia-derived revascularization, it is 16 versus 10% for CABG. So that is why when we compare the two modalities, the CABG versus PCI, it's almost always the TVRs, and sometimes the myocardial infarction, which drives the outcomes in favor of CABG. So these are the results of the 25 trials, the 5-year results, and you can see the target vesicle failure in both Resolute and Zion stents over a 5-year times were staggering. That is 16 and 18%. And again, the major cardiac events were 19 and 22%. So based on this, what are the causes of stent failure or TLRs and TVRs? We all know that it could be inappropriate stent expansion. Lesion coverage is not appropriate. There is new atherosclerosis when it comes to stent thrombosis, and there can be late incomplete stent deposition. So this is the stent size and expansion, the main predictor of stent failure. If you look at this slide, we can know the p-value less than 0.001. It is for in patient in which the MLA is less than 4.5, or there is either distal or proximal narrowing. That is, you have missed the target. So if you correct these points, that is malapposition, under expansion, and also lesion coverage is appropriate, you can definitely reduce the TLRs and TVRs, improving the profile for PCI. So to defy the risk of TVR, TLR, we know that we should ensure proper lesion preparation and assessment. We should ensure the stent is proper site, there is no geographical miss. We should ensure that the proper stent length is taken. We should ensure the proper stent is deployed, that is, there is no malapposition, there is no under deployment of the stent, and we should also detect then managed stent edge issues, if any. There is no edge dissection for that matter. So with all these parameters are met, we can definitely reduce the TLRs and TVRs, thus improving the profile of PCI when it compares to CABG. So PCI with intracoronary imaging can solve all these issues. That is why the concept of precision PCI has come into the system over the last few years now. So we have two modalities, IVUS and OCT. IVUS and OCT differ with each other in terms of the functioning. IVUS uses the ultrasound waves, while the OCT uses the near-infrared rays. Based on these findings and each individual properties, IVUS has improved penetration, while OCT compared to IVUS is increased magnification and also increased or improved resolution when compared to IVUS. So what's the evidence behind IVUS? If you look at the recent trials, this is the IVUS XPL trials in which the IVUS was used in large stents, and the patient with 1,400 patient was divided into two groups. That is, those lesion which the lesion length was more than 28 millimeter. And if you look at the graph on the right side, the 1-year clinical outcome, it was quite significant. That is, the TLRs and TVRs were 2.9% when IVUS-guided PCI was done, and it was 5.8%. That is, we reduced the TVRs and TRs to almost 50% within 1 year. And it was significant at 5 years as well, and you see that the graphs are still deviating over a period of 5 years. And if you extrapolate them over a period of 10 years and 15 years, we still think that the graphs will further deviate. Thus, IVUS-guided PCI definitely has improved outcomes when it comes to coronary angiography-guided PCI. Another trial, which is the ultimate trial, which randomized patient to IVUS-guided versus angiography-guided. And this was the first trial in which a specific criteria was used. So I'll spend a minute on this, slide just to make sure that you understand this. So the optimized results are considered if the minimal luminal area is more than 5 millimeters square, or if the vessel is small and the luminal area, or the stent area for that matter, is more than 90% of the distal reference area, we consider the stent is well deployed. And in addition to that, we should also make sure that the plaque burden at either side is less than 50%. That is, there is no geographical miss. So if these criteria is met, the stent is considered to be well deployed and appropriately sized as well. So these are the results. 1 year outcome was, again, you can see 2.9 versus 5.4 when it comes to target vessel failure. And over a period of 3 years, it was again 6 versus 10. That is, there was almost 50% reduction of events when it comes to IVUS-guided PCI using the ultimate criteria. So this is the Renovate trial, which is used complex lesions, that is syntax score or average was more than 26. And again, this was recently published in a journal, and it showed that at the end of 1 year, 7 versus 12% event rate was seen when angiography guided was considered compared to this. And it is sub-study when OCT guided PCI versus IVUS and versus angiography. OCT and IVUS has almost equivalent result, and both were superior to angiography guided PCI when it comes to endpoints in terms of TVRs and TLRs. OCT, as you all know, it uses optimal coherence tomography, it uses infrared rays, and an important trial was Illumine trial, which showed non-inferiority of OCT compared to IVUS. So based on this, the stent sizing algorithm was based on EEL to EL, which is extra elastic membrane, and the reference diameter was taken, and it was considered to be acceptable if the MSA was more than 90% of the distal reference area. So based on this, the primary endpoint showed significant non-inferiority, that is as good at IVUS when it comes to sizing the vessel, and also it was also considered much safer to IVUS when it was in detecting dissections. You see it was able to detect 28% lesser amount of dissection was seen when it compared to IVUS and angiography guided. IVUS had 40% of dissections, among which major was 26%, which shows that IVUS is not as good as OCT when it comes to the resolution of intracoronary vessel. So simply, we can use the MLD max criteria for optimization of the results. MLD is the pre-stent assessment of morphology, length, and diameter. And based on morphology, we can do vessel sizing and also vessel preparation. Either we can use rotablation if the need be. And after the procedure, we can use the max, which is the assessment of dissection, apposition, and expansion. And based on specific criteria, we can make sure that the stent is properly deployed. So which patient benefit from imaging guidance? So these are two kinds of different images. If the patient has a simple coronary lesion, we can save 1 life by treating 116 patients. However, in complex lesion, in high MACE, and those patients who have calcific lesions, significant stenosis, left main, bifurcation, the NNT is 37. And this NNT is quite good. It is as good as giving a statin to a patient for primary prevention. So this is the results of patients having imaging guidance. So my take-home message is that TLRs and TVRs, as we all know, are the Achilles heels of coronary angiography and PCI, improved by reducing the incidence of ISRs and STs. IVUS OCT can improve stent traumatization and reduce stent failure. There's a plethora of data now, and now in the recent guidelines, it is given as class 2A recommendation for both simple and complex PCIs. Evidence is existent for IVUS and is emerging for OCT still further. Guidelines in imaging PCI, as I said, 2A for left main stenting and stent traumatization and failure. Cost is an issue. In our part of the world, cost is definitely an issue, so we must consider IVUS or OCT in certain cases when the stakes are quite high. Those patients who have left main bifurcation lesions, who have complex lesions like Medina 1-1 LED diagonal lesions, complex lesions, CTOs, diffuse calcific lesions. In all these patients, we can use the IVUS. The system can improve the outcomes. So thank you very much for your patience.